Good. Whew, what a week. All right, so tonight, sorry, when I say what a week, I mean I've been busting it. Um, this is my last week of orders at the base, which is nice. I just work straight through the weekend. That part sucks. But we got class tonight, which tonight won't be too bad. I want to say there's like 80 something slides, maybe 84, somewhere around in there. When you take out the intro slides and then the review at the end. Um, so it won't be too bad. Tonight we are going to cover behavioral emergencies, or the title says psychiatric emergencies, but it's not just that. We're going to be covering pretty much anything to do, everything from basic anxiety attack all the way up to actual psychiatric emergencies. So when we go into this, I want you to kind of keep an open mind. Just like the patients that you come across aren't all going to have Alzheimer's, they're not all going to be demented or anything like that. You want to keep an open mind so you don't walk in getting the wrong idea and then over assess or badger your patient or confine them when they don't need it, that kind of thing. Let me get through these couple of slides real quick. All right, we're going to jump right into it. It is 7 o'clock. Let me fix this.
Hey, Mr. Robert, it's 6 o'clock.
6. Oh, I'm sorry. I'm Eastern time while I'm on the set of orders, so it's 7 for me. My bad. Thank you.
Copy.
That's the kind of week I've had right there. All right, anyway, so EMTs often care for patients experiencing a behavioral crisis or a psychiatric emergency. Like it says on the slide, these crises can be the result of acute medical situations where something just kind of came up, say a diabetic emergency, mental illness, mind-altering substances, which we've talked about, stress, and many other causes. So the first thing I want to do is kind of dispel a couple of myths. Now, like I say, you think about psychiatric emergencies, you think immediately of somebody having a psychotic episode, they're getting violent, or they're out of their head. And while those are possibilities, that's not the only thing, right? And it's not always because there's something wrong in their brain. So at some point, most people experience an emotional crisis. Doesn't mean that everyone develops a mental illness. So we'll take. I'm gonna try to word this in a way that doesn't make me sound wrong, but take depression for example. And I'm not knocking depression at all, but like for example, I myself have little bouts where I just kind of let the weight of the world push me down. It doesn't necessarily mean that I've got depression. It just means that right then and there and in that little bit of time frame, I might be depressed. It's not chronic. It's not lifelong. It's just I need a break and I haven't gotten one. That kind of thing. Sometimes that's what you're going to deal with, and then sometimes it is going to be the chronic depression, the kind that it hits you and it stays with you for weeks, for months, for however long, and it doesn't go away. As an example, sometimes otherwise healthy people may sustain acute or temporary mental health issues. Sometimes they do just come and go. So don't jump to the conclusion that a patient is mentally ill just because they're experiencing some of the behaviors that we're going to talk about tonight. The most common misconception about mental illness is that if you are feeling bad or depressed, you must be sick. And they're talking about sick in the head. That's not the case, right? You may be perfectly fine. In fact, a lot of times you are perfectly fine. You're just having a bad run of it. It is possible for us to not be happy all the time. There are many justifiable reasons for feeling depressed. You could be going through some major life changes, right? So divorce, death of a relative or a friend, any of those feelings of loss, feelings of failure, feelings of inadequacy, any of that kind of stuff can really put you for a loop. Many people believe that all individuals with mental health disorders are dangerous, violent, or otherwise unmanageable. Absolutely not the case. Only a small percentage of people with mental health problems are going to fall into these categories, like a really small percentage. It doesn't mean you shouldn't be safe. Scene safety always comes first. But don't think that because somebody's not quite in their right mind that they're going to be violent. And I know that up until this point, we've kind of tied that together with altered mental status, and that's a little bit different. All right. So if somebody's at risk of a fight or flight response, then yes, they might become a little dangerous. But if you've got somebody that's just like, say, Alzheimer's, for example, where they're under the influence, but there's nothing about it that's going to make them violent. Same thing with depression. There's nothing about it that's going to make them violent. They're just not, they're not completely on the tracks at the moment. And it could be for any of the reasons that we've already talked about. EMTs may be exposed to a higher proportion of violent patients because they are seeing people who are, by definition, considered to be having a behavioral crisis. So, yes, sometimes you are going to come across those violent patients. But if that's all you're getting called out for, you're not seeing 1,000 normal day people walking around in between your calls. You're only going out for calls. I always called it, like, for example, with me in the military as a medic, war's greatest hits is how I've worded it in the past. You don't see the thousands of troops that go overseas and come back perfectly fine. Or, the worst thing that happened to them was they sprained their ankle playing basketball or something like that. We don't really see that as medics. We see the people that got shot, the people that got blown up, and that's it. And then we go back to our base, and then we go out again, and we see more people that got shot, more people that got blown up, and we have to deal with that. That's almost all we see every time we go to work, per se. That's what we see, and even in the civilian world here, that's going to be kind of what you guys deal with. Not always, especially on the trauma side. Trauma is not as bad here as it is in a war zone, but when you factor in medical calls, behavioral calls like this, yeah, you do start to see it starts to feel like that's all you're doing after a while. So, that being said, try not to let your own stress and your own burnout get out of hand when you're dealing with this stuff. Um, Try to remember that, that may be all you're seeing, but if you're only seeing a patient a day or even two or three a day, that's when you think about the overall population, that's barely a blip in the radar. Communication is key. In some cases, patients will de-escalate when the level of trust is established. So we're going to talk about that more tonight, about how to get your patients to listen to you, where you can be the voice of reason when the rest of the world is going crazy around them. Um, and although you cannot determine what has caused a person's crisis, you may be able to predict whether the person will become violent. And sometimes that is going to be, um, you're going to kind of have that. You might actually have that idea before you even get on scene. So defining a behavioral crisis, behavior is what you can see of a person's response to the environment. That's his or her actions. So you can't see Alzheimer's, you can't see dementia, but you can see how they're reacting from it, right? So their behavior is what they're doing. And that's the key here. We're not walking diagnosis machines. So you can't look at somebody and be like, you have Alzheimer's. It doesn't work that way. Or, look at somebody and say, you have depression. We don't know. There's like 16 years worth of school to go to something like that. But from an action reaction response, or aspect, we can kind of get an idea from there. And that's what we're going to focus on, is what are they doing, not necessarily what's wrong with them, even though we're going to talk about the different things. I want you guys to keep this in mind from an aspect of if this were a real call, what would you see and what would you do? Most of the time, people respond in reasonable ways. Whenever it becomes a behavioral emergency, it's where they're no longer able to process things like they should. Over the years, people learn to adapt to a variety of situations in daily life, including stress. Sometimes stress is so great that the normal way of coping isn't enough. And so we start to go into negative coping mechanisms, right? So, for example, um, a good way of coping that we teach in the military, we call them pillars of resilience. We have exercise, eating healthy, hanging out with friends, being part of something bigger than yourself, um, learn something new, pick up a hobby, those kind of things. Those are positive ways of coping with your stress. When those start to fail you, though, we tend to replace them with things that may work better in the short term, but they're destructive. So, drugs, alcohol, um, insert vice here, whatever it is that gets your mind off of things. And it may work, but it's not a good long term fix. And you come out of it worse off than when you went into it. So reactions to stress that are acute and those that develop over time can create a crisis, especially when you start falling into bad coping mechanisms. The change in behavior may be considered inappropriate or not normal by the person who calls 911. So if you are, let's say it's a person with a caretaker and person starts acting weird, caretaker is probably going to be like, that's not normal, so I'm going to call 911. Usually it takes a stark, fast difference to do so. If it's something that's slow over a couple of days, they may not notice it. And so they probably won't call you. The calls you're going to get are the ones where somebody just 10 minutes ago started acting out of their head, that kind of thing. A behavioral crisis. Let me get to the right slide. We talked about that. There we go. The behavioral crisis or psychiatric emergency includes patients of all ages who exhibit agitated, violent, uncooperative behavior or who are a danger to themselves or others. EMS is called when the behavior has become unacceptable to the patient, the family, or the community. And because obviously other people can call 911 for you, sometimes it's just a matter of what's their limit. Sometimes they waited a long time to call you. Sometimes they're like, I just don't want to deal with you. I'm going to call 911. They're going to come pick you up and take you and get you out of my hair. I hate to say that and I hate to see that, but that does happen where it's just they don't want to deal with it. Those are typically the patients that wind up in nursing homes and left behind. That's the thing that sucks the most. All right. A patient may have dementia or depression, behavior that may interfere with activities of daily living. So a lot of times, if you like, for example, if you've got somebody with those, they either are in a home because they need the help, or they've got a caretaker, be it family or somebody hired or anything of that sort. And then chronic depression. Like, yes, there is a such thing, like you said, Tiffany, there is a very real thing called chronic depression. This is a persistent feeling of sadness and despair, and it may be a symptom of a mental health disorder. If it's there and it's not going away, um, that's when it's a problem. But if you just have a couple of down days, that's normal, right? There is a difference. Not to say you shouldn't act accordingly and figure out why it's that bad and do something to fix it. But a lot of times it's just, all right, I've been in the dumps lately. What's going on? And I reevaluate my days. It's like, oh, I stopped going to the gym when things got tough. Maybe I should go try to get a workout. Or I've been eating like shit. Maybe I should actually try to clean up my diet a little bit and I'll feel better. That kind of thing. When a psychiatric emergency arises, the patient may show agitation or violence, and it may become a threat to their self or others. The magnitude of mental health disorders is pretty vast. According to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. But this is broad, right? It's not saying that tens of millions of people have depression or tens of millions of people have PTSD. It's all of it. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders are the most common mental health disorders, and they're pretty. We talk about anxiety attacks like they're a specific thing. Um, they're really not. They can be a couple different. They can be caused by some different things. They can be the result of specific things, broad things. Just sometimes it's physiological. Sometimes it's not even the world around you that cause it. But we have generalized anxiety disorder, panic disorders, social or other phobias. So like I have a friend who is, unless she's going to either work or the grocery store, she's afraid to leave her apartment. She will not go to a restaurant by herself. She will not go to a bar by herself. Um, it's actually she has a hard time going and running alone in the park in the middle of the daytime by herself, kind of thing. Um, I don't know I don't know how to like I want to help her with that, but I have no clue how to do it. Post-traumatic stress disorder, PTSD, that is kind of the story of my life, basically, because of the military. Like everybody I know has some level of PTSD, and it's not just us. People that went through Katrina. For those of y'all that remember that storm, when that hit us, there were a lot of people that I grew up with that had PTSD from that storm. and some storms since. Um, I know that my dad had trouble after Camille hit, because I mean that was his era. That was before me, but um, it doesn't have to be a war zone. It's just too much stress over a long period of time. You start to have a hard time coming back down from it. And then OCD, obsessive compulsive disorder. The U.S. mental health system provides many levels of assistance to people with psychological conditions. So, professional counselors are available for marital conflicts and parenting issues, sometimes free of charge, depending on if your organization covers it or not. The military's got a lot of great things out there for people that need the help. More serious issues, such as clinical depression, are often handled by a psychologist. Anybody tell me the difference between a psychologist and a psychiatrist? Okay, one's a doctor, one can write prescriptions. Good. Okay. One listens, one one creates diagnosis. Check it, you got the right idea, but you're backwards on it. So the psychologist listens to you. They're the ones that you'll sit down and talk to, and they try to give you ideas on how to cope, or even just listen to you. Where if that's all you want is just somebody to vent to, they'll do that. Um, but it's the other way around. The psychologist will listen to you. I think of it like if you took a college class called psychology. You're learning about how people think, you're learning about social behavior, stuff like that. So the psychologist handles that. The psychiatrist is the doctor. They're the yeah. But I mean, hey, you were on the right track. People mix them up all the time. The psychiatrist is the one that's a doctor. He can prescribe you meds, and he has spent probably about half of his life in school to become what he is. Because first of all, they had to get their bachelor's degree, then they had to go to med school, then they did their residency, then they did their specialty, which is another 4 years on top of that. So 16 years just to start as a psychiatrist. They're the ones that can give the meds. Um, but they're also usually not your first step. So anytime we're talking about the two different positions in here, just keep that in mind. If we say psychologist, we're talking about trying to get something off your chest. That is the beauty of it is that, like I said, because some people don't have a legit actual illness or like mental issue, so they don't necessarily need medication. They just may need some advice or some help getting through a tough spot. Psychologists are fantastic for that. And even if you do wind up needing a psychiatrist to give you meds, a lot of health systems want you to talk to a psychologist first, because it's not enough just to give you Wellbutrin or something. They want you to also try to develop some coping mechanisms that are good. So, like for example, the VA, when we have troops that are getting diagnosed with PTSD, we don't just immediately start handing them medicine. I mean, as much as the military loves to do that, don't get me wrong, um, we don't. That's not where we start. We'll set them up with an appointment for a psychologist. The psychologist does a couple things. They coach them through, start to give them some coping mechanisms. They are also assessing them to see what their suicide risk is and stuff like that. And then based on what the psychologist says, because they're experts in their field as well, then the person may get meds. They may just have learned a new coping skill and they're fine. It just depends on what the problem is. But most psychological disorders can be handled through outpatient visits where you just go in, talk, and then leave. Some people require hospitalization in specialized psychiatric units. So there you go, psychiatric. Now you're getting into the medical side. And that can be for a couple things. It could be because you're a danger to yourself or others. It could just be that they recognize that there may be something physiologically wrong and they want to do some tests to figure that out. Where psychology may just not be enough for what's going on. Psychiatric disorders may have underlying causes. So, social and situational stress, such as a divorce or a death of a loved one, diseases such as schizophrenia, Alzheimer's, that kind of thing. Physical illnesses such as diabetic emergencies can cause this, because remember, now you're messing with the brain. So, it may not be something you normally have, but you're going to start to see those issues while you're having those diabetic problems. Chemical problems such as alcohol or drug abuse, especially because I've seen this in a friend of mine. She got into some bad drugs when we were teenagers, her and a couple other guys that I went to school with. And one day, while they were out of their mind on whatever they were doing, she got hurt. She got hit in the head while under the influence, and she basically got stuck in a weird mental state. I mean, obviously the high wore off, but she was never herself after that. She's got some serious mental shortcomings that the doctors, all they can say is that it was because her brain was under the effect of that stuff when it hit, and so the repair process didn't work right, and it messed some things up. Biological disturbances such as electrolyte imbalances can cause it. Sometimes these conditions are compounded by noncompliance with prescribed medication regimens. So if you're supposed to take something like Wellbutrin or Adderall or whatever it is, and then you don't, um, that can mess with you as far as giving you a behavioral emergency. And then on the flip side, you can take medicine, you can abuse it, take too much of it, and then you're at risk of having a problem on that side of the spectrum. All right, for the patho, an EMT is not responsible for diagnosing the underlying cause of a behavioral crisis or a psychiatric emergency. Like I said, we're going to talk about a lot of the different ones that are out there, but nobody expects you to look at a patient and go, you have Alzheimer's or something like that. I mean, they may tell you if they've been diagnosed, but you're not, the psychiatrist and the psychologist will figure that stuff out. Our job is just to take care of them and keep ourselves safe from whatever they're actually physically doing in response to what's wrong with them, while we get them to the hospital or get them to somewhere where they can be seen and taken care of. So you should understand the two basic categories of diagnosis a physician will use. You have organic, which is physical, and functional, which is psychological. All right, so for organic disorders, organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or physiologic functioning of the brain. So here we're talking about some things that are physically there, right? So a sudden illness, say you got an infection of some sort. Um, an example would be a UTI, right? Urinary tract infection. Even though that's down around the kidneys, once it gets into your bloodstream, it's going to start circulating all over the body, and the brain's going to start to suffer and have a hard time dealing with that. Traumatic brain injuries from trauma, seizure disorders, drug and alcohol abuse, overdose, or withdrawal, diseases of the brain such as Alzheimer's disease and meningitis. And then altered mental status can arise from hypoglycemia if you're diabetic, hypoxia, impaired cerebral blood flow, or hyper or hypothermia. If you get too hot or too cold, that can start to mess with your brain. We like our nice, comfortable 98.6. That's what we're always looking for. All right, for functional disorders, a functional disorder is a physiological disorder that impairs bodily function when the body seems to be structurally normal. So these are a little bit difficult because even if you go to the hospital and you run labs or any kind of medical tests, it may not show anything. Examples include schizophrenia, anxiety conditions, and depression. You can't get tested like in a lab for depression. And that's one of the reasons why it's so hard to accurately diagnose people with whether or not they have it. We think that a lot more people have real depression than what we have officially in our numbers because it's so hard to really pin down. A safe approach to a behavioral crisis. So as an EMT, your regular EMT skills are going to be what you have to rely on. So think about your assessment, right? We always start with scene safety. So your patient approach, the assessment, patient communication, obtaining your history, and providing care are used in the behavioral crisis. You're still going to do everything um, as far as your assessment goes. Now, granted, there's not a lot we can do to fix anything. So everything that we do is going to be centered around safety and comfort for both you and the patient. Other management techniques are also involved. So like if you show up, assess the scene, make sure they're safe, make sure you're safe, ensure you have a means of communication. know where the exits are in case something does happen. You really need to be able to get out of there quick. So, and I'm almost positive the slides are going to say this later on, but don't let the patient get between you and the exit. That's usually bad because then if something does go wrong, you got to get past them. And if you've ever watched a football game, you know that's not always okay or not always possible. Don personal protective equipment, have a definite plan of action. Urgently de-escalate the patient's level of agitation. That can be very difficult. And it may not be possible for you. It may be that, they just don't like you. For whatever reason, you mean mugged them or whatever. If you have a RBF or something like that, and they just get that wrong first impression, and they're not quite 100% on their game mentally, so it's much more apparent to them. Um, that's you may ruin your chance to get on their good side the minute you walk in the door, and it may not have even been anything you did. You might have just been the first one, and they didn't like the way you looked, so you may have to let your partner take over. Whichever one of you has the better rapport should be the one to take lead. Calmly identify yourself, be direct, be prepared to spend extra time. Stay with your patient, don't leave them alone, but don't get too close, especially if they're volatile, if they might be potentially dangerous or in a situation where if they get threatened, they may lash out. Express interest in the patient's story. That doesn't mean buy into it, right? If they say they see purple elephants and the FBI is chasing them and stuff like that, then don't be like, oh, I see it too. But don't be aloof. Don't ignore them. Don't make them feel like you're laughing at them or anything like that. Avoid fighting with the patient. Be honest and reassuring, and don't judge. All right. For your scene size up, scene safety is huge. This is going to be one of those situations. There's a couple chapters in the book where I say this. Your scene safety is in every assessment, right? No matter what you do. Somebody falls and stubs their toe, scene safety. But here it's critical, okay? Because you're dealing with somebody who usually is not going to be violent. On the grand scheme of things, most of your behavioral patients aren't going to be violent. But if anybody has a propensity to be violent, these would be it. Because you never know. Like I said, you may, depending on what it is, it could be that they're just not in their right mind. Um, it could be that I'm losing my train of thought here. They're if they have if it is something major, like say they're hearing voices, if those voices tell them that you would make a nice dinner, um, and they and they agree, then that kind of thing, you want to keep your distance. At least don't get too close to them. Don't get to where they can grab you. So is the situation potentially dangerous for you or your partner? Do you need law enforcement? Don't be afraid to call them. But if you don't really need them, if you get in there and you're like, oh, this is a completely nonviolent thing, and I don't see any reason to think that they need to be there, then don't bring them, because sometimes the presence of uniformed officers can make a situation worse than it ever would have been without it. If it is a bad situation, if somebody's walking up and down the street and highly agitated, screaming, throwing stuff at people, that kind of thing, you may want to just go ahead and hang back and let law enforcement take lead to secure it. It's perfectly fine. Are there legal issues involved? Is it a crime scene? Anything to do with consent? Or can you get a refusal? That kind of thing. Take appropriate standard precautions and request any additional resources you may need. Check out your mechanism of injury. If there is one, your nature of illness is usually just going to be behavioral. If I give you a behavioral emergency in boot camp, let me rephrase it. If I give you more than one, because we're going to have to go through different things, I'm probably messing with you at that point. Just so maybe you're struggling with it, or maybe you're a hot shot and I'm trying to give you something hard. But even then, I'm not going to really give you too many curveballs. But usually, a behavioral issue is medical, and so you're going to be dealing with the nature of illness, not necessarily a mechanism of injury. So figure it out, and then note any medications or substances that may contribute to the complaint, or that may be for treatment of a relevant medical condition. For your primary assessment, form a general impression. Again, remember that's usually sick, not sick. Now, that sometimes it's easy to see when you're looking at a heart patient or somebody going into shock, but when you're dealing with behavioral patients, there's not a lot of outward signs. You're not going to see cool, clammy skin. You're not going to see, red flushing skin or modeling or anything like that. You're just going to see a person that is not acting normal, and they may look normal to you, but they're just not normal to the people that know them. So, and that's the thing. They may be calm, collected, absolutely nothing wrong, but there's just some reason somebody called 911. Figure it out. You may have to talk to them, talk to somebody around them, and see. Begin your assessment from the doorway, or at least from a distance, mainly because we're worried about our scene safety. Until you kind of treat it like a hazmat scene, in a sense, where you don't just rush in and then figure out, oh crap, maybe I shouldn't have gotten so close. Kind of work your way in. Just be tactful, be discreet when you're doing that, because you don't want your patient to feel like they are a hazmat scene. I'm not saying be that overt about it. Begin with an introduction of who you are. Make sure they know that. Make sure they know that who you represent, who you're, that you're there to help, that kind of thing. And let the patient know. Don't. This is one of those situations where you don't want to just be like, "Hey, I'm Rob. What's up?" Because they're going to look at you like, "Well, I don't know you." But if you say, "Hey, I'm Rob. I'm an EMT. I heard you were having a hard time. Let's talk about it. Is there anything that I can help you with? What's going on?" Then they kind of know why you're there, and it's a little bit different. All right, perform a rapid physical exam. For behavioral patients, unless there is obvious trauma involved, you're not going to have to do a head to toe. But if it looks like there might have been, if they say they're outside and there's a ladder laying on the ground, you think they might have fallen. If there's any kind of sign that they might have hurt themselves, especially their head, then yes, you're going to check and see if there's any trauma, because that may be what's wrong. They may have hit their head on something. Observe the patient closely. Use the AVPU scale to check for alertness. Establish a rapport with the patient. And again, sometimes that's the hardest thing you can do. And sometimes it's just not possible. Most medical or trauma situations will include a behavioral component. So treat the whole patient, the behavioral component, as well as the medical or traumatic issue. If they have a behavioral issue, don't just ignore the fact that they broke their leg or something like that. It just, you got to treat it all. For your airway and breathing, if your patient's in physical distress, assess the airway to make sure it is patent and adequate. If they're up talking, then usually you're fine on your airway. Evaluate the patient's breathing and obtain the rate and effort. Um, when you're dealing with anxiety, sometimes they're going to be hyperventilating. So that's going to be one of the things that you look for. Use a pulse ox if available. So in these cases, we're not jumping straight to high flow. We're trying to titrate their oxygen if they need it, and if they'll take it. Depending on what's going on, they may not want anything around their face. They may be too agitated, too high strung. So you're not going to be able to put a non-rebreather or a cannula up there. If that's the case, and you're looking at their O2 sats and they need oxygen, ask them if you can hold it in front of their face. I'm not going to put this on you, but I need to get this near so you can breathe the air. Will you hold it by your face, or can I hold it by your face? That kind of thing. For your circulation, you're going to assess the pulse rate, quality, and rhythm. Evaluate for the presence of shock or bleeding, just to make sure. Like I said, sometimes the behavioral issue is because they were in a traumatic incident. Assess your patient's perfusion by evaluating skin color. It should be warm, pink, and dry. No, not completely dry, but not like soaking wet either. Transport decision. If they're not in their right mind, they should be a high priority for transport. For your history taking, get your sample. Depending on the issue, you're going to get some out of the box answers for this, like, signs and symptoms. You're not really going to get headache, nausea, that kind of thing. You're going to get, well, they're not using good words, or they're much more agitated, or, they seem to not know where they are, that kind of thing. And then the rest of your stuff, your allergies, medications, pertinent medical history, what they ate, and everything, those are always usually going to be pretty standard. Consider 3 major areas as possible contributors. That is the patient's central nervous system functioning properly? Are hallucinogens or other drugs or alcohol a factor? Um, some people that you would never think would do drugs are very big drug heads. Elderly, a lot of elderly are on drugs. Hey, they earned it, but sometimes it's that's their coping mechanism because again, they're people they knew and grew up with and spent their whole life with maybe passing away, and that's massively depressing on its own. So yeah, when you get out into the general community, you'd be surprised how many geriatrics you find that are, um, abusing their pills, trying to sleep, trying to stay wound down, that kind of thing. So sometimes that really does play a part. Are significant life changes, symptoms, or illness caused by mental rather than physical factors involved? These are just some things you want to think about. Um, just a couple takeaways on this slide. In geriatrics, consider Alzheimer's disease and dementia. We're going to have an actual Alzheimer's disease class, a specific class that is taught by somebody a whole lot more knowledgeable on it than I am when we do your boot camps. Your assessment has two primary goals, which is basically just major life threats and then reduce their stress of the situation. Because again, like I said, most of what we do is going to be comfort and support. Unless there's a traumatic injury or something we have to really attend to, there's not a lot we can do. And then use reflective listening. Can anybody tell me what that means? Yeah, pretty much. Just pare back what they say. Not exactly. I mean, you're not playing Pete and repeat, but if they tell you something, if you can rephrase it as a question, like you want more information on it, do so. It trying to, yeah, exactly. It kind of gets them to start talking more about what's going on, and it gives you a much better idea into what's actually going on in their head. Um, and depending on the situation, sometimes just figuring that out, or even for your patient, them just talking about it, just trying to tell you what's going on, sometimes will be therapeutic in itself because now they're getting it off their chest, and they may not have been before. For your secondary assessment, for your physical exam, um, rule out trauma, especially in the head. If they're unconscious, begin with the physical exam. Don't bother with sample, right? Because if they're unconscious, we have a major problem. Conduct a detailed physical exam and obtain a complete set of vitals. Get your vitals only if it's possible to do so without worsening their emotional condition. Sometimes when you go to put something on their arm, and I know what a blood pressure cuff does. I expect it to get tight on my arm, that kind of thing, and everybody in a normal day does as well. Um, and your patient probably normally does too. But depending on what's going on, you put that thing on their arm and you don't tell them, hey, this is going to squeeze your arm a little bit, they may freak. Or even just you getting close into their personal bubble and touching them that way. Um, checking the pulse, that kind of thing. That could cause them to kind of freak out as well. But do your best. Try to get it if you can. Um, consider whether prior events such as physical agitation, use of stimulants, alcohol withdrawal, or a taser. Funny story about that one. If a taser may be contributing to the patient's condition. When examining a patient with a behavioral emergency, check for track marks indicating drug abuse and for signs of self mutilation. And if you're going to, well, I won't say that because I don't want you guys trying to take off your patient's shoes. But if you're expecting, I'll put it to you this way: if you are ever concerned, and this is a bit of a tangent, but since we're talking about looking for track marks, if you're ever concerned about a possible human trafficking situation, and you think that drug use might be involved in one way or the other, you're usually not going to find the track marks in their arm. They're not going to make it, whoever's keeping them under the influence is not going to make it that obvious. One of the easiest places to get somebody where you don't see that kind of thing is between the toes. So if you're dealing with somebody and you ever have that concern, when you get them in the back of the ambulance, in the spirit in your head to toe, take their shoes off and look between their toes. See if you see any track marks there. That's a huge, huge, huge red flag, because most of your drug users are not going to bother doing that. They don't really give a shit. They're going to just go ahead and stick themselves wherever they can easily do it. You can tell a lot about a patient's emotional state from facial expressions, pulse rate, and respirations. Tears, sweating, and blushing may also be significant indicators of a state of mind. They have that 1,000-yard stare. You might want to stay a little bit further out of arm's reach. Look in the patient's eyes. A blank gaze or rapidly moving eyes may mean the patient is experiencing central nervous system dysfunction. If their pupils are not acting properly, like if they're not dilating and constricting together, that could be a problem there. For your transport decision, when available, have law enforcement personnel or firefighters accompany you in the back of the ambulance. You really don't want to be alone if you can help it. Now, granted, some behavioral emergency patients, they may be fine as long as it's just you. So sometimes the best thing is to be alone. But if you're ever concerned about a patient turning violent, or you needing some kind of real help for restraint or something like that, get somebody in the back with you. And if you can't, we've most everybody has seen what the back of an ambulance looks like. If somebody's having a behavioral emergency, the absolute worst place you can prop up is going to be in that captain's chair behind their back, because they can't see you, right? So whether it's just you or whether you have a rider, both of you will do pretty good to strap in where they can see both of you. That way, there's no concern over whether or not you're doing something behind them or you're a threat all of a sudden and that kind of thing. Man, y'all having connection problems tonight. Transport by ground rather than by air, if at all possible. There's really no reason to put a behavioral emergency in the back of a helicopter. Try to make the patient comfortable. And for your reassessment, never let your guard down. A lot of times patients will act spontaneously. Sometimes there's no build up or warning. If they're physiologically stable, meaning that their vital signs are fine, they're not restrained, they're whatever, everything is just in their mental state of mind that's a problem, then you can reassess them every 15 minutes. But if they're unstable or if they're restrained, they need to be every 5 minutes, especially if they're restrained. All right. I know we talked about it before at the beginning of the course that patients have died in restraints because they're in positions that asphyxiate them, or in positions that put pressure on, say, like a certain nerve or an artery or something like that, and it messes with their vital signs. So if you have to restrain your patient, it doesn't matter if there's anything wrong with them or not. They're going to still be assessed as if they are a unstable patient. Reassess any interventions that you might have done. And there's often little you can do during the short time you will be treating the patient again, but that's perfectly fine. I mean, there's really not a lot to do anyway. Your job is twofold. You're going to diffuse and control the situation. That's your primary goal, is to keep everything calm, and then safely transport the patient to the hospital. Intervene only as much as it takes to accomplish these tasks. The more you do, the more they're probably going to start to get anxious, because they're going to start to wonder why you're doing so much. What's going on? Document thoroughly. Um, if you had to restrain, document every possible thing about it. How did you restrain them? Who restrained them? When did it happen? Why did it happen? All that stuff, because it may wind up in court, and you never know how long it may be before it does. So you don't want to be 5 years down the road trying to remember this one random call or you had to restrain somebody, while a lawyer is trying to pick you apart over it. All right, I know it's only 6:45. But we're going to take a little bit of a break because we're switching gears into what different problems are out there. So take 10, be back at 6:55, and we'll continue on. All right, so we're going to get back on this. Um, so now we're going to go over the different types, and we're going to be kind of broad with it for the most part because there's a lot of them out there. And again, with you guys not being um, expected to diagnose and understand all the different ones, thankfully, the new curriculum has cut down on them. Right? They've revamped it. It used to be we have to sit here and talk about every single one, and it was as painful for the instructor as it is for the student, because even our eyes would glaze over trying to go over them all when what you do as an EMT is the exact same thing. Um, so from here to the end of the chapter, we are talking about a broad overview, and that's exactly what we expect you to have is just a general knowledge of what's out there. We don't expect you to be psychiatrist or psychologist or anything like that. We'll start with acute psychosis. Psychosis is a state of delusion in which the person is out of touch with reality. All right, so this is, again, there's a couple different versions within this. This is a blanket term. Affected people live in their own reality of ideas and feelings, and to them, it's normal. So that's the thing. Like you're looking on people on the outside looking in, the person's crazy, to put it bluntly. But for the person that's in the moment, in that psychosis, the world is crazy. Um, they are fine to themselves. So, causes of psychotic episodes, mind altering substances, intense stress, delusional disorders, and schizophrenia. Some episodes can last for brief periods, others will just stick and they'll never go away, like my friend. Um, Schizophrenia is what we're going to talk about first. Schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early childhood, with symptoms becoming more prominent over time. So, the older you get, the worse it gets. Influences that are thought to contribute to the disorder: brain damage, which is what happened to my friend, genetics, and psychological and social influences. Some symptoms include delusions, hallucinations, a lack of interest in pleasure, erratic speech. Guidelines for dealing with a psychotic patient: first of all, scene safety. Make sure they know who you are, even if it somewhere in their mind and their psychosis it gets construed. You still want to make sure that you at least attempt to make sure they know who you are. Be calm, direct, and straightforward. Maintain an emotional distance, not just a physical distance, but an emotional one. Because sometimes they're whatever's going on, they may be bawling their eyes out. They could be experiencing any emotion, depending on what they're having, what their brain's going through. Don't argue, but don't agree either. If they say something that's completely off the wall, like, "Oh my God, I see snakes crawling up the wall," or "the picture is bleeding," or something like that, uh, don't look at it and go, "Oh my God, I see it too." Don't do that. All right. Explain what you would like to do. Involve people who the patient trusts, such as family or friends, to gain patient's cooperation. And when I talk about telling them what you want to do, if you remember, I said earlier in the class, if you're going to do something, even if they're unconscious, say what you're going to do. This is another one, even though they may be awake, same thing. All right. Just basically think out loud. When you get ready to do vital signs, when the thought crosses your head, you say, "I'm going to get a set of vitals. I'm going to start with the blood pressure. This is a blood pressure cuff. I'm going to put this on your arm. Is that okay? It is going to get kind of tight as it takes its reading, but it's going to loosen up, and then I'll have it off of you in a few seconds." And just go from there. Excited delirium. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is a behavior characterized by restless and irregular physical activity. Although patients experiencing delirium are generally not dangerous, if they exhibit agitated behavior, treat them as such. So keep your distance, call law enforcement if you need to, because they may strike out irrationally, especially if they think that you're attacking them first. In such cases, your personal safety must be considered. Some symptoms that you're going to see: hyperactive, irrational behavior, vivid hallucinations. All right, so Amityville horror type stuff, if it goes that route, but either way, it's going to be something that to them looks very, very real. Hypertension, tachycardia, diaphoresis, and dilated pupils. If you think you can safely approach the patient, be calm, supportive, and empathetic. Um, be an active listener. So nod at them, acknowledge that you are understanding what they're saying. indicate that. Limit your interruptions of the patient's comments. So let them finish their thoughts before you start trying to be too active, right? So the the yeah, okay, that kind of thing, limit that. Approach the patient slowly and purposely and respect the patient's personal space. So when you start to see from your patient that it looks like you're getting a little too close to them, stop there. If you're still out of reach and you can't do vitals, you just can't do vitals. If they look stable, that's okay. And then just document it as such that you couldn't get vitals. Use careful interviewing to assess the patient's cognitive functioning. Try to indirectly determine the patient's orientation, memory, concentration, judgment, and pay particular attention to the patient's ability to communicate clearly. Make notes of the patient's apparent mood, and if it changes, try to make note of that as well. If the patient appears to be experiencing an overdose, take all medication bottles or illegal substances with you to the medical facility. The patient should be transported to a hospital with psychiatric facilities. So, not all hospitals have them. In fact, even Forest General, as big as they are, technically, I don't think they have it. I could be wrong. I think they just rely on Pine Grove because it's sitting right there. But we can only go ER to ER. So even if you know your patient is destined for Pine Grove, if you got for you students that are in the Hattiesburg area in South Mississippi, um, yeah, that's not where you're going to take them. You won't take your patient to Pine Grove. You'll take them to the ER, and then they will get transferred to Pine Grove from there. But you want to try to get them to a facility that's either got the capability in the hospital or very, very close nearby. You don't want to take them to a hospital where they're going to wind up getting transferred another 45 minutes away or something like that. So for you guys in that area, Poplarville is not the best place to go. FGH now has psych rooms for, okay, awesome. I know for a long time there, they were just relying on Pine Grove, but that being a different entity, I figured it's only a matter of time before they started doing it themselves. Uncontrolled or poorly controlled patient agitation can lead to sudden death. Can either be from cardiopulmonary arrest, if they go into sudden cardiac arrest. Physical agitation thought to result from metabolic acidosis. Physical control measures, including tasers. A couple years back, and I may have already told you all this, I don't remember. We had to respond to the same high school twice in the same day because the same student got tased by the same cop twice in the same day. Once in the morning, once in the afternoon. We heard him come across the radio in the morning, said subject has been tased. This is the SRO. And then we heard him come across the radio about an hour after lunch and said subject has been tased again. And that was an interesting day. Positional asphyxia, which occurs, this is why we don't use long boards like we used to, is because of this right here, positional asphyxia. This occurs when the patient's physical position restricts chest wall movements or causes airway obstruction. That can happen even on non-traumatic patients. So make sure that you put them in that position of comfort. If they don't need to be laying flat, don't lay them flat. Pre-hospital patients, restraint reduces the possibility of patient injury as long as it's done properly. The potential for injury to EMS providers and allows for safe and appropriate treatment of an uncooperative patient. So the NAEMSP, the National Association of EMS Physicians, recommends that every pre-hospital care transport provider create and follow a plan and a protocol for restraints. And a lot of times that plan usually says call your med control, but it is what it is. Such protocols consider the appropriateness of the restraint, the types of restraints, the care provided to the patient following the restraint, and your protocol must consider the laws of your state. If the laws don't say you can restrain, then you just can't restrain. There's a wide variety in pre-hospital patient restraint protocols throughout the country, so know yours. That's not something we can teach you, especially with how widespread the students are in this class. Protocols should include only the use of restraint devices that have been approved. So some, for example, will use soft restraints only. In the military, we use leather, just because some of us are strong enough to rip through soft restraints, so it really doesn't do us any good. Hard restraints include plastic ties, handcuffs, or leather restraints. The method of restraint chosen should be the least restrictive method that will ensure the safety of the patient. So in other words, don't bind them head to foot like a mummy if all you need to do is restrain their hands. Risk associated with restraint. Let me get you guys to the right slide. I'm not there yet. All right. Personnel must be properly trained. You guys that work for an ambulance agency and stuff like that, y'all should be pulling out the restraints and practicing. You can practice on each other just to make sure you know how to use them. You don't have to fully restrain somebody, but just like, for example, leather restraints are weird. Um, you have a cuff for each wrist, a cuff for each ankle. They bind together to keep, and then those two bindings bind together. So your patient can still walk around. Like if we put somebody in restraints in the military, they can still get up and walk around, but they can't raise their hands over their head, for example. They can't bring them further than shoulder width apart. They can't take a step. They can't get a gait bigger than what a normal walking step would be. That way, they have their freedom of movement, but they can't get too out of control. That's just how we do it. It's different for different places. But if I just toss somebody a bag of leather restraints and say, "Here, put this on," and you look at it and you're like, "There's no buckles anywhere on this. How am I supposed to use it?" Well, I mean, you don't want to be on the scene when that's the thought that goes through your head. So pull them out, try them. Soft restraints are easy. They're usually just Velcro and like a strap, but um, depending on what y'all use, it may not be that simple. Legal actions against you can involve several types of charges if you do this wrong: assault, battery, false imprisonment, and violation of civil rights. Now, if you're doing what you're supposed to do, yes, you can still be sued. However, through the course of it, they're going to find out that you did what you were supposed to do. And just because you get sued doesn't mean you're going to lose. So anybody can sue, but you want to make sure that you're doing everything right, because you don't want to be the one that winds up losing the case. You may use restraints only to protect yourself or others from bodily harm. You may only use reasonable force as necessary to control the patient. All right, so the process of restraining a patient, we're actually going to go over a lot of this at the boot camp, so I'm not going to really hit too much about this here, but communication is key. There should be, I'm going to talk about this just because you may see this on your tests. There should be 5 people, one for each extremity and one for the head. So this is not a solo effort. You don't just toss somebody's head of restraints and say, "Here, tie him up," and then I'm going to like step out and have a beer or something. That's not how it works. All right. In fact, you usually, if you're going to restrain somebody, law enforcement should definitely be on the scene, right? Because the only reason you're restraining them is because you're not safe. So you should have help. So if you can get 5 people, get 5 people. There should be a team leader. Usually, it's the person at the head, and use the minimum force necessary. All right. Avoid direct eye contact and respect the patient's personal space until necessary. Never leave a restrained patient unattended, because they can hurt themselves. Restraints, or even the soft restraints, can cause harm if a patient's not careful. 4-point restraints, where both arms and both legs, are preferred for uncooperative patients. Don't place anything over the patient's face, head, or neck, because it's going to make it harder for them to breathe. If the patient is spitting, you can put a surgical mask on them. That's different. It's not like you're placing a sheet or a pillow over them. But it should be loose. If the patient attempts to bite you, because sometimes that'll happen, if they're chomping at you, um, have somebody try to restrain their head while you put a cervical collar on them. If you put a C collar on them, they're not going to be able to move their neck enough. They're just going to be kind of stuck like they are. But if you do that, now you have to start monitoring their airway, right? Because if they're trying to bite you and they're salivating, and I mean, it could be rabies that's getting them like this. The foaming at the mouth and stuff can obstruct their airway, so you want to be careful with that. And then monitor, like it says, monitor for changes in level of consciousness. All right, for your potentially violent patient, violent patients make up only a small percentage, like we said at the very beginning of the class. Not everybody's going to try to bite your ear off, or sorry, Mike Tyson. Not everybody's going to try to do something um, that's violent, right? Most people they're not in their right mind, and they're having a behavioral reaction. It could be any reaction other than the normal. It's not always going to be violence. However, the potential is there, so you have to keep that in mind. Assess the level of danger based on the following risk factors. For history, has the patient previously been hostile? If they were hostile before, they're probably going to be hostile again. Their posturing, do they look like they're getting ready to attack you? If anybody's been in, like, especially guys, you know, think back to high school. You see two kids on the playground getting ready to fight. What do? They bow up on each other. Or, you start seeing hands being made into fists. The fists come up. They get into that kind of a hunched position, like they're getting ready to lunge at you. These are the kind of things you want to watch out for. If they're just sitting back talking to you or standing with their hands in their pockets, which I would call that a yellow flag, because I'd like to be able to see the hands of the patient that's having a behavioral emergency. But if they're not, if they're just kind of like kicking a rock around and looking down like they're shy, that kind of thing, then I really don't worry too much. What about the scene? Is the patient holding or near, or is they near a potentially lethal device like a knife, a gun, something they can use against you? Vocal activity. Which kind of speech is the patient using? Are they cursing you up, spitting you out, that kind of thing? Or are they talking calmly and like normal to you? Physical activity. The motor activity of a person undergoing a psychiatric emergency may be the most telling factor of all. So if they have tense muscles, clenched fists, a glare in their eye, if they're pacing, can't sit still, these kind of things are going to be red flags that they may be violent. So just be careful of that. So other factors to consider: you have poor impulse control, a history of truancy, fighting, and uncontrollable temper. So people that go and it's a little bit of drinking, a little bit of fighting, it's a good night, that kind of thing. If they have a behavioral emergency, they're probably going to want to fight. That's their normal. That's just their route. History of substance abuse, depression, which accounts for 20% of violent attacks. I had no idea about that one, but okay. And then functional disorder. If the patient tells you voices are telling him or her to kill, believe it. And a lot of times they will listen. That's the thing. It's not just that they're hearing the voices. It's that a lot of times those voices are misconstrued as being their own conscious or their own thoughts, and then so they're going to follow through. Yeah, it's crazy to bite someone's ear off, but Tyson did it. Was it who was the boxer? Was it Evander Holyfield? He's going way back. You got to be kind of close to my age to remember that one. It was back when Mike Tyson stopped being famous for a while because he did that. But he wasn't even having a problem. He was just losing the fight, which was new to him because he that dude was so good he had video games made after him. All right, suicide. Depression is the single most significant factor that contributes to suicide. We really don't know a lot of the reasons why people do it. It's really big in certain demographics, like the military. We only make up, what is it? The military makes up less than 2 or 3% of the population, but we're something like 27% of suicides. And it was Holyfield. Okay, I thought so. Um, it's a common misconception that people who threaten suicide never commit it. Usually the threats come before the actual act. Yes, so they may be making a threat and not planning on following through with it, but the fact that they're there is still a red flag. If if that's their cry for help and people's response is you're faking it, you're not going to follow through, then well, the next time they're not going to bother trying to ask for help. They're just going to do it. So that's a stigma that really should go away. It doesn't matter whether they are actually going to do it or if they're just making a cry for help. It needs to be taken care of. So threatening suicide is an indication that someone is in a crisis that he or she cannot handle alone. Immediately intervene as necessary, and intervening would be, hey, I'm going to hang out with you for a little bit, and we're going to go get some help, and I'm not going to leave you alone. I'm not going to let you have the opportunity to be by yourself to possibly go through with something that you can't take back. So be alert to these warning signs. Does the patient have an air of tearfulness, sadness, deep despair, or hopelessness that suggests depression? Does the patient avoid eye contact, speak slowly or haltingly, and project a sense of vacancy as if he or she is really not there? Does the patient seem unable to talk about the future, unable to think about it, no plans? Is there any suggestion of suicide? And does the patient have any specific plans related to death? You'll also see some other things, like they may be giving away all their stuff. Um, that's a big one, right? We naturally want to keep the things that we've worked for. If you see somebody just handing off everything, like, here, have my PlayStation, here, have my car, I'm not going to need it, that kind of thing. That's a huge red flag. What are you planning on doing that you don't need your stuff, or at least need compensation for it? Consider the following additional risk factors. Are there any unsafe objects in the patient's hands or nearby? Is the environment unsafe? Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Underlying medical conditions? Are there cultural or religious beliefs promoting suicide? Some Japanese cultures, they believe that if they have disgraced themselves or their family, that suicide is their penance for it. So I forget, there's an actual term for that, where you fall on your own sword. That still today still exists. Has there been trauma? A suicidal patient may be homicidal as well. So if you believe you're in danger, obtain police intervention. If they're not afraid to kill themselves, they're probably not going to be afraid to kill you either if there's some anger mixed in there. The most important service you can provide for a suicidal patient is compassionate transport to a medical facility where the patient can receive proper treatment. And I will tell you this, you may not want to tell them this, but the proper treatment is not going to be fun. It's like basic training without the exercise. They strip you down, take away any ability or anything that you can hurt yourself with, and then start building you up from scratch. That's how they do it at Pine Grove. A buddy of mine that actually worked, he was a paramedic. We worked together. Um, Damn, you know what? If I should have got him to come in and teach this part, because when he we do when he would do our refreshers, he has no problem talking about it. Um, he went through a tough time, lost his wife, was going through a divorce, damn near lost his job, all kinds of things going against him, and he was about to end it. He walked out into his backyard, had his letter all written up, had a pistol in his hand, um, and just at the last minute decided he couldn't do it. But he was ready up until that point, and he went and got help. And he said that the treatment to get better was actually harder for him than the stuff that got him to that situation in the first place, but it worked. So it definitely won't be sunshine and roses, but if it works, it works, and that's what matters. All right, PTSD. Again, this and suicide, like I said, we you tend to hear about it more with the military, but it can be anybody. You don't have to go to war to get PTSD. This can occur after exposure to or injury from a traumatic event. Some examples are sexual and physical assault, child abuse, serious accidents, natural disasters. There's war, pretty far down on the list, to kind of help drive that point home. And then loss of a loved one or stressful life changes. There's an estimated 7 to 8% of the general population that has PTSD at some point in their lives. Military personnel who have experienced combat have a high incidence of PTSD. Reminders of their experiences in the military from news coverage or gatherings of veterans can also be triggers. Also, loud claps. I actually had an episode the other day that scared the hell out of me. I'm at a Mexican restaurant right off base, and somebody dropped something, a piece of wood or a chair. I forget what I think it was a chair. And the way that it landed on the floor, which was a wooden floor as well, sounded like a gunshot. And I just was almost under the table taking cover before I even realized what was going on. I was like, wait a minute, no, 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 I'm in a Mexican restaurant in Atlanta. Like that's not going to happen here. But the knee jerk reaction was just like, holy crap, that came out of nowhere. And then with that, after that was over, came hot flashes, hyperventilation. I'm sitting here like just kind of head in my hands, just watching my reaction to it, you seeing how I recovered from it. It's the first time that I can at least recall that I've had that issue to that extent. I've had things pop off and scare me before, but I've never had like a legit oh shit moment like that. Um, so I mean that happens. It happens to people from any walk of life. People in Chicago have this problem. People in New Orleans have this problem. People in Poplarville have this problem. Um, any stressful situation can cause it, and then things that remind you of it can give you the same response. So signs and symptoms of PTSD include feelings of helplessness, anxiety, anger, and fear. People with this may avoid things that remind them of the trauma, including loud noises or smells, and sometimes avoid interactions with other people. You may also find that they get what's called hypervigilance, where they, everything stays buttoned up. They lock everything. They basically go into fortress mode. Though their pets will go from golden retrievers to attack dog kind of things because they're always worried about what might get to them. So they may suffer constant nervous system arousal that is not easily suppressed. So in other words, their heart rate's going to kick up, and they can't bring it down. They're going to have anxiety attacks. They can't bring them down. They can't get their breathing to slow down. That kind of thing. Their senses are sharpened and mental acuity is heightened, which sounds like a normal thing, but that's actually a stress response, and it will exhaust you physically if you can't come down from that. They can relive the traumatic event through intrusive thoughts or nightmares, even flashbacks. Combat vets, in particular, may be prone to early heart disease, higher incidence of type 2 diabetes, loss of brain gray matter. And another consideration for the combat vet is the higher incidence of traumatic brain injury sustained from traumatic, like secondary to an explosion. If anybody's been caught by an IED, even if they don't have a direct hit from it, sometimes that concussive shock wave will mess with people. Symptoms may go undiagnosed for several reasons. First of all, people don't like to admit that things are bothering them. That's the big thing, right? And nobody can diagnose you with something if you never go to the hospital. Patients may downplay their symptoms. Healthcare providers should eliminate excessive noise, refrain from touching or doing anything to the vet without an explanation, and keep their diesel equipment far away. Caring for your combat vet. The returning combat veteran is a patient who will require a unique level of understanding, compassion, and specialized attention. We had a World War II vet that lived in the town in Poplarville, right behind the Hardys. Real nice guy, and he had some behavioral issues, not so much like what we talk about in this chapter, but he had some PTSD. They called it shell shock back when in World War II, but it was the same thing. He had PTSD, but he also had a lot of really awesome stories. And so when we would go talk to him when he's having a hard time, um, we first of all we would sit down and we'd start talking about like, well, what's bothering you, and he'd get to talking, and we would kind of like direct the conversation into, well, you were never we weren't here in World War II. What was it? What was flying the planes like? What was different about them then than it is now? And we just kind of start to shift the conversation into things that would might have been good memories, or like, oh wow, that's awesome moments, that kind of thing, and they would calm him down. Um, Sometimes that's what you got. All you got to do is you don't even have to change the topic, just change the aspect of it, right? Not everything about being deployed is bad. In fact, I actually enjoy my deployments for the most part. There's only been a couple times that it really went to shit on me, and then here I'm still here, so that's really all that matters. Um, so just be careful how you phrase your questions. If you're going to do something like that, make sure you don't start bringing them down another negative route. Use a calm, firm voice, but be in charge. Respect the veteran's personal space. If they don't want to talk about it, you're not going to convince them otherwise. Limit the number of people involved or move to a private and quiet space, and ask about suicidal intentions. If you're going to ask about suicide, ask about homicide too. They go together. Suicidal or homicidal ideations. Military personnel are trained to use weapons and are resourceful at improvising weapons. Ensure that there is nothing the patient can access and use as one. Physical restraint will not be effective with this population, and may simply escalate the problem. It's awesome that they put that in the lesson plan. If it's necessary to calm the patient, especially if there are safety concerns, chemical restraints by a paramedic is going to be what you go with. So call in a paramedic, have them, hey, I'm going to give you something that's make you feel real good, and just put them to sleep. It's the easiest way to do it. All right, medical legal considerations, and this is actually the end of the lecture, so we're almost done. This is a short night. This chapter used to be painstakingly long. I like how they restructured it. The medical and legal aspects of emergency medical care become more complicated when the patient is undergoing a behavioral crisis or a psychiatric emergency. So legal problems are reduced when the patient consents to care. Get them to do it. Yes, they can say no, but again, if they're not in their right mind, well, sorry, you can't really you can't refuse. But it does not. It's going to suck to just get, even if you know you're going to win, it's going to suck just to have to go through all that. Gaining the patient's confidence is a critical task. If at all possible, try to do that. Once you've determined that a patient has impaired mental capacity, you must decide whether he or she requires immediate emergency medical care. Just because they're not in their right mind doesn't mean you still have to do something. Alzheimer's patients, for example, if they're having an episode and it's purely mental, there's no physiologic issues going on, and they're still in the care of somebody who understands their situation, then you may not have to take them to the hospital. Their caretaker usually has power of attorney and will be able to make that decision where they can't. A patient in a mentally unstable condition may resist your attempt. So if that's the case, then don't assault them. Don't leave your patient alone. Doing so may result in harm to the patient and can expose you to civil action or abandonment. Request law enforcement personnel to handle the patient if you have to. For consent, implied consent is assumed with a patient who is not mentally competent to grant consent. But again, if they have a caretaker and the caretaker is there, that person can take the liability for saying that they're going to deny treatment. But if you feel like they need it, then treat it like anybody else. If they need the treatment, try to convince the caretaker, to let you do what needs to be done. Consent matters are not always clear cut in psychiatric emergencies. A lot of times there's gray areas. It's kind of a pain in the ass to figure out, but I mean, that's the way it goes. If you're not sure, request law enforcement personnel or guidance from med control. When in doubt, call the med control, because they're masters at when you can and can't do something. And if they tell you to do something, no matter what, and if there's altered level of consciousness, what they're doing is they are taking the legal liability. So there's that. That goes back to that first discussion question that we did in module 1. The EMT has limited legal authority to require or force a patient to undergo emergency medical care if there's no life threats. So if there's not a life threat, you can't. It gets very hard for you to justify forcing things. You should be familiar with your local and state protocols. A competent adult has the right to refuse, even if life-saving care is involved, if they are in their right mind. In psychiatric cases, a court of law would probably consider your actions in providing life-saving care, to be appropriate. So even if it comes down to a court, they can say no. But if you say no, you will die, then you can act against their will technically. Yes, you will probably wind up in court, but the court's usually going to side in your favor for that. A patient who is in any way impaired may not be considered competent to refuse. Always maintain a high index of suspicion regarding the patient's condition. Err on the side of treatment and transport, and carefully document everything. The more you start to get legal red flags going off in your head, the more you should be documenting. If you wind up writing a novel, fantastic. All right, that is it for behavioral emergencies. Any questions so far? I'm working on your pen. As soon as I find my notepad, I'm gonna put it. Did I put everybody to sleep? Are y'all still with me?
I'm here. Struggle is real, but I'm here.
This is a dry chapter. It really is. And dry in lecture is dry in skills as well. All right. So yeah, okay. Do me a favor, Tammy. Unmute and talk about it.
I just found a site that's called EMT Review. It's free, and it goes through reviews and stuff before we take our big test and things to prepare.
Just an additional resource for y'all. You guys can never have too many. I mean, we provide stuff, but by no means should you ever limit yourself to just what we offer. If it's a good program that's out there, then by all means. So cool. They put it in the text, EMT review. Anything that helps. All right, your pin for the night is going to be BC, so Bravo Charlie, 22B, as in Bravo again. So BC 22B. There you go. Yeah, I used the JB Learning and an app called Pocket Prep when I was working on paramedic, and they're really good. They're free to a point if you want the like all the questions that the test bank has for those app, not the actual registered test bank, but what those apps have. You got to pay a little bit, but it's not bad, and it's a one-time payment just to unlock it. So if there's no other questions, guys, I will talk to y'all whenever you need me, and we'll have class again on Tuesday. I do want to say this before I stop the recording. I have to go back and look, but I think we only have 2 chapters left of Module 3. So if you're behind on your tests, now is the time to catch them up because this is a huge module, and I don't want you guys to like log in the night before a module test and realize you still got like 15 chapters to catch up. But I don't think anybody's that far behind. If not, yeah, I know, right? Hurricane Omega is getting to that point. All right, guys, y'all have a good night, and